You will. Awesome.
Sounds good to me.
Good afternoon, everyone. Hope everyone's doing well today. My name is Adam Thompson. I'm a consultant here with CQII. I'm located here in New Jersey, where we had just a very weird ice snow thing that just ran through. So I just wanted to sort of say hello from cold, snowy Jersey. I hope things are going well in y'all's part of the country. This afternoon, what we want to talk about is this concept of health numeracy. I presented this to the country in Ryan White programs about almost 10 years ago at this point. I went back into the literature to kind of see, hey, what's been going on in the health numeracy space? And so one thing I want to say is, unfortunately, not a lot. It seems to be that we still have some really big gaps in our sort of country and people's knowledge and understanding of health numeracy. And most of the approaches that folks were taking to improve health numeracy were still pretty much the same. So what we're going to talk about today is health numeracy pretty broadly, and then dive into some areas where folks who would like to improve the quality of their care by looking at health numeracy as a construct will give you some spaces and places that you might be able to do some work to improve some outcomes related to things like especially self-management. So I'm going to go ahead and pull up our slides for today. Shay, can you see those? Excellent. Awesome. So Zoom introduction real quick. We were just talking about this. If you have not been in the pandemic for the past 2 years living on Zoom, like many of us, quick orientation to the tool. There's going to be some icons located at the bottom of your screen. Those icons will let you, bottom or top, depending on where your screen icons are. And those icons are going to let you do a couple things. You can mute and unmute your line so that when we get to any discussion points, or if you would like to ask a question, feel free to unmute your line and ask that. You can also turn your video on and off. While we're lecturing and have slides up, we can't really see you anyway. So, feel free to give yourself a Zoom break. But when we pull the slides down and we are in a discussion mode, we would really encourage you and invite you to turn on your cameras. You can also take a look and see who else is joining us today with the participants icon. We also have a chat room so that if you would like to ask questions, but maybe you're in a busy office and if you unmute, there's going to be a lot of noise. Feel free to use the chat room to make any comments or ask any questions. We also have reactions. So if you hear something that you like, you can give us a heart or a thumbs up. And if you don't like it, there's a host of other reactions that you are invited to bring into the space. If for any reason you decide that you would like to exit our TA webinar immediately, do not pass go. You are able to hit the leave room button down there at the bottom, and that will take you out of our meeting. A couple of things for folks. If you do have your cameras on and for any reason you can't hear us, you can kind of put your hand up, kind of point to your ears, let us know that folks can't hear. If you have anything to share, you can raise your hand, although while we're sharing slides, we would encourage you to raise your hand in the reactions. If you have a technical problem, you can put your thumbs like this or let us know in the chat room. And our applause can be done by moving your hands like this. A couple of thoughts for Zoom. If you've not labeled your Zoom tile, feel free to do that. It helps us with our attendance. We already talked about our video and our mute. Use hand signals if you feel so inclined. Use the chat room to post any clarifications or questions or share your wisdom. If you do have questions and they particularly relate to a situation in your environment, one thing that we do ask is please try to eliminate any personal or private health information. We do try to create a brave space of learning. So if you got a question, ask it. Now is the time. We do record these sessions to allow others to learn. So just an update right there. So our agenda for today, we've already gone over our welcome and a little bit. We'll do our objectives. Then we'll talk about health numeracy and decision making, factors related to understanding quantitative health information, skills and competencies for understanding, and tips for presenting. Our learning objectives are to increase knowledge of patient and provider factors that contribute to patient understanding of numeric health information, identify skills and competencies required for accessing, analyzing, and applying quantitative health information, and identifying best practice and tips for presenting quantitative health information. So we got a question for you, and I'll invite folks to use the chat room here. So someone that I know was diagnosed with type 1 diabetes as an adult. It was kind of one of those very shocking diagnoses. They were in a coma, ketoacidosis. It was like real bad. They got out of the hospital. They had some amputations on their feet, from their toes, from the sort of trauma associated with the coma. And then about 2 years later, they got diagnosed with gastric cancer, which resulted in having to have part of their stomach removed. So this patient was seeing multiple providers for a bunch of different conditions and diseases, including a primary care doctor. Through the course of this treatment, they were recommended by one provider to consume at least 8 glasses of water a day for their condition. The same patient was told by another provider to consume 4 glasses of water a day for their condition. So my question that I have for you all is, how many glasses of water do we think that patient drank?
4.
So we got 4. One vote for 4. Anyone say? We got 6, 4, 6, 2, 8,
12.
12, right?
Yeah.
Let's go all in. 12. So what ended up happening is the patient drank 6 glasses of water a day, because that was directly in the middle of 8 and 4. And they thought, I'll apply common sense here, do a little bit of math, put it in the middle, drink 6 glasses. Here's the thing about that. That's not 8 or 4, right? So at the end of the day, the patient is not drinking the amount of water that either provider suggested. And so maybe not sort of compliant in either direction. This patient was my mom. I watched her sort of struggle with so much quantitative information, particularly after her diabetes diagnosis. But when her conditions got more complex and she was recently diagnosed with lupus, there's all these math coming at her left and right. The thing to also know about my mother, she's worked in public health for probably about 40 years. She was the director of the Pregnancy and Nutrition Surveillance System in West Virginia. She did work with Deloitte & Touche, helping the CDC do their birth height weight algorithms. This is a woman that knows math, right? And yet, in the context of her healthcare, when she was being, given this information about what she needed to do in order to be adherent to her treatment and kind of get the best outcome, this woman, who I know, I'm her son, I obviously think she's a wonderful human being, but she's pretty darn smart when it comes to this stuff. And I watch her struggle daily with it. So one of the things that we want to sort of like bring sort of to our awareness as we talk about health numeracy, and we'll show you a little bit of the impact in a minute, is that this is not about your education level, right? You could have a PhD and still, in the face of quantitative information presented in a health context, kind of lose all of those tools and skills in the moment, because it's a different space and place. It's a different conversation. People hear things differently when your life is the subject of the conversation. So when we talk about health numeracy, we don't want folks to just associate this immediately with this idea that it's patients, who are just not up to speed, right? Maybe they don't have the best education. You could have the very best education and still suffer in a health numeracy environment. The reason is, in healthcare, we have numbers everywhere, right? Especially we have things that talk about our weight. As people with HIV, I remember learning early on about AIDS wasting, and they kept telling us it was if we lost 10% of our body weight in a month, right, was sort of this number that we were supposed to keep track of. I was a methamphetamine addict when I was diagnosed with HIV. Gaining weight, losing weight, that was sort of like the whole recovery process for me for years. And they would say, lose 10 pounds. Well, from when? At what point? And is 10%, how much is that? I didn't even know how to do that math. Then you had things like carbs, right? I watched my mom sit in the grocery store, right, and try to understand and read these boxes and start to do this math. We finally got her a smartphone so that she could kind of sit there and crunch the numbers. But what I noticed is she just got frustrated sitting in the grocery store, constantly crunching all these numbers, right? Trying to understand, could she buy this? Getting so frustrated to the point that she just doesn't want to go to the grocery store anymore, because her whole experience of food is now that it is managed and frustrated, and there's numbers, and no matter what she does, her glucose is going to go up, another number she doesn't understand. So she just says, I don't want to go to the grocery store because it frustrates her. So now you've got my mother who's aging. She lives alone in Erie, Pennsylvania. It's snowy, it's cold, and now she doesn't want to go to the grocery store. There's not much else that pulls her out of the house right now besides Zoom calls with her grandkids, right? And this experience of numbers and food and her healthcare are even affecting sort of what she wants to do in her daily life. We also saw the example I gave you a little bit earlier about the glasses of water. And then anyone who supported somebody who's had to manage something like diabetes knows how difficult it is for people to associate the carbs in the food with the numbers that come after you eat and how much insulin you're supposed to take. We are bombarded as patients with expectations of doing math and calculating and understanding numbers in a way that a lot of people who spend their whole day in healthcare don't understand. A good example of that, this is a lab sheet, right? So as I mentioned a little bit earlier, I'm a person with HIV. This was from a couple years ago. I went into my patient portal, which is supposed to be that access point that helps all patients sort of understand and take control of their healthcare. And this is the chart that I get when I go into my patient portal. So you can see here, we've got some tests there on the left. A lot of those have acronyms that now that I work in healthcare, I have a little bit more sense of what they are, but I can still tell you most of these I don't completely conceptually understand. And then you see my value, and then you see a standard range, and then what the units are. The thing about these standard ranges, however, is like, is my number going up or down? Do I want it to be closer to the bottom or closer to the top number? If it's increasing, is that bad? If it's decreasing, is that worse? There are all of these factors that relate to what these numbers mean and what I'm supposed to do with them. I finally remember when I was a new patient kind of seeing this and saying, okay, I need to ask about this. And I went up to my doctor and said, hey, can you help me understand these numbers, right? Like, what does this mean? What should I be looking at? And I was basically told like, oh, most of that, we're just checking to make sure everything's okay. Don't worry about it. But those are my numbers. That's me on that paper. If you make that number, I'm worried about it, right? That is just how it is. And so when I looked at it, it was important to me that if this was something that was being tracked in my healthcare, that I have some sense of what it is, why you're doing it, so that I can understand what's happening inside my own body. Patients are given these kinds of test results all the time. As I mentioned earlier, I'm helping co-manage sort of my mom's care as a caregiver and support. And I have access to her patient portal. Every test that comes in, I have no idea what these people are saying. I get numbers that have to do with scans and radiology, and then I've got to go to Google, start looking it up and try to even understand what it is I'm looking at so that I can even know what questions I need to ask. And unfortunately, all the people who ran these tests know exactly what these are, right? And the people who are interpreting them and understanding them, and yet they're left sitting in front of patients with often no pathway to interpretation. And then when you do go to get it interpreted, sometimes people just tell you, oh, don't worry about it. So how does this affect our decision-making, right? Health numeracy, we got these numbers all around us. We're constantly being asked to do something. So what does this mean? Health numeracy is defined literally by how we do with numbers. It's the degree to which individuals have the capacity to access, process, interpret, communicate, and act on numerical, quantitative, graphical, biostatistical, and probabilistic, that's a mouthful, health information needed to make effective health decisions. So what does this do to decision making? Having fewer numeric skills is associated with lower comprehension and less use of health information, right? So if I don't have the skills, I end up not using the information, right? Or I use it, but I don't understand it. You end up in a place like my mom with the 4 glasses, 8 glasses, she drinks 6, because that just made sense. Many patients actually cannot perform the basic numeric tasks required to function in a current health environment. For example, 26% of persons in one study were unable to understand information about when an appointment was scheduled. Think about that. That is 1/4 of individuals in this sample that couldn't understand when their next medical visit was. And then, as I mentioned earlier, 16% of highly educated people incorrectly answered straightforward questions about risk magnitude. So trying to understand when someone says you're at increased risk, or you have a 5% chance, increase that this will happen, or your odds are increased by 1.2. Most folks don't understand those kinds of comparisons. And a lot of this problem, I think, is because when we've talked about health literacy traditionally, although I'll say it's getting much, much better, it's usually only about sort of patients, right? Health literacy is about patient ability. But we're seeing more about a health literacy environment and what does it mean to be thinking about the system and how literate is that system and how prepared is that system to support individuals with either limited health literacy or what I think is just like your average health literacy that you're going to find in the community. While many times patients have to learn new things to manage a new disease, I get that, but we shouldn't have to become mathematical, experts to be able to walk through our daily lives, right, with a healthcare condition. One of the things they suggest is that this definition should not just include patients, but should include how that information is delivered to patients, how the environment structures and thinks about it, so that we're not simply rooting the problem in a patient who doesn't understand, but we root the problem where we actually have a solution, which is how the health system thinks about and communicates quantitative information. So when thinking about quantitative information and the factors that contributes to a patient's ability to sort of use, manipulate, analyze, and process all the things we just talked about in our definition, there's actually kind of three things that you have to think about here. This is from a multidisciplinary literature review that was conducted in 2007. And this schematic and concept model sort of really identifies both the patient and the provider as seats of where you need to think about how health information is communicated, understood, and comprehended. But they also add in this third piece, which is the information itself, right? How the information is designed beyond the person communicating it and the person receiving it, but what is the sort of style and substance of the communication itself. So let's take a look specifically now at the patient factors. So when thinking about a patient's ability to use quantitative information, the first factor relates to the patient's quantitative skills. So the definition of this are just basic computation skills. Can a person successfully complete addition and multiplication and use a simple formula? This also includes things like estimation, right? So if somebody gives you sort of two things and say, is this half of this? Can you kind of like estimate what that looks like? As well as statistical literacy, being able to understand percentages and risk in relation to something. Examples of this could be individuals who have to think about computing calorie content. So the example I gave being in the grocery store, comparing computation to estimate to determine whether it's correct, understanding the concept of randomization in a clinical trial, right? So this relates not only to thinking about how a person or a patient may use this information in the management of their care, but even thinking about when we're offered the opportunity to participate in research, that we understand the informed consent part of that research. A second factor that contributes to a patient's ability to use quantitative information is the ability to use that information. And this is defined as the ability to navigate the documents that the information is contained on, to interpret the graphs, right? The visualization, the way the information is presented, and be able to translate between different representations of the same information. This is why often we recommend telling people, if you put a statistic, give me a picture next to it. Show me that in a different way. It doesn't just help people who are visual learners, it also helps people with limited health numeracy, where the number presented in that numerical format may be the less accessible piece, and the visualization helps provide enough context around the numerical information that people can build the bridge, right? And that's where comprehension takes place. This can be things like trying to obtain nutrient information from a nutrition label, right? Being able to understand it to move it over. Comparing personal health data as displayed on different meters or devices, right? I know a lot of folks in the pandemic probably either were recommended or saw or maybe had at home the pulse oxygen meters. It seemed pretty simple. I kept turning the button on, but then there were like 5,000 numbers that came up and I never really kind of understood which way I was supposed to look. So it was a great tool. I understood what to do with the numbers, but what I didn't know how to do was sort of take those numbers and then put them into, am I okay? Another factor that contributes are patients' oral communication skills. So this has to do with a person's ability to speak clearly about quantities and understand spoken information. So this could be like being able to report a previous medication regimen accurately to a new physician. So if someone wants to know, how often did you take this medication? How many pills did you take? What was the frequency? What was the dosing, right? These are all questions someone could be asked, and being able to have the oral communication skills to say that back, right? It's also that you sort of understand not only what you're saying, but what's being said to you. The last factor here is the information design. This relates to how the information is sort of arranged, the symbols that are used to support comprehension and cognition. So are they familiar to people, right? Like we can create a great visualization that we understand, but sometimes if the symbols that are used or the graphics aren't familiar, or you've got symbols that are not culturally relevant or responsive to the communities that you're serving or trying to communicate with, you could end up with information that is there and it's understandable, but it's not necessarily appropriate or designed in the way that the people you're trying to reach are able to access it. So an example like this could be designing a patient interface for an electronic health record that provides graphics to illustrate numerical information. So unlike the chart of lab results that I showed a little earlier, this would be giving me a graph showing me over time, maybe having arrows going up or down, indicating, whether that's a good or a bad trend that we're seeing. When you look at these factors, one of the things I want to identify for folks is that if you think that health numeracy is something that you want to work on as far as a quality improvement project, these factors would be areas that you could think about understanding a little bit more. There are assessments out there that you can adopt that look at patients' quantitative skills. There's one available. Basically you read an ice cream label and you have to answer these 4 questions about it. The one thing I will say about that tool, folks used it and then they said, oh, everybody scored low, so they stopped using it. Everybody scored low because the United States has a very low level of health numeracy. So if you pick up a numeracy assessment tool and you find that your patient population is grossly limited in their health numeracy, don't think the tool is wrong. Think that that's a place you got to do a lot of work. You could also be looking at how you evaluate your tools and resources that you create that have numerical information by testing that with patients who have to understand it. Putting those graphical representations in front of people, focus groups, key informant interviews, right? What does this information say to you? Making sure that the information design that you probably worked really hard on is accessible and appropriate to the people that you designed it for, right? When you think about oral communication skills, there are some great patient self-management programs out there. I know specifically the one from Stanford is a program that a lot of folks use. All of these, while they're not aimed specifically at health numeracy, they contain components of this, and they do help patients and caregivers and family learn how to better communicate their needs to healthcare systems. But as we saw in the definition, it's not just about patient factors, right? There are these provider factors as well. And these mirror sort of what you see in the patient, only it has more to do with how providers communicate and understand the information, and can they make it accessible to the patients and communities and caregivers that they're speaking with. So the provider factors that you could focus in on are things like the provider's oral communication skills, their ability to communicate quantitative concepts clearly to patients. This could be things like explaining a new medication regimen to a patient in an understandable fashion. A lot of folks I know, they leave their healthcare visits. We know we're supposed to take this pill, but if you start asking us how many times and when, you start getting a little bit less clarity, right? So really, really thinking about how are we communicating? There was one example I heard about in one of the lectures one time where folks were saying, you got to think about it too, if you're serving a community whose primary language is not English, how we say things in English might sound differently in another language. So for example, if you say once in English, that can sound a lot like once in Spanish. You can end up taking things way more than once a day. So you have to be thinking about not only sort of communication skills in general, but really be thinking about, the differences in the communities that you serve and really making sure that providers' oral communication skills are not just sort of up there in being able to communicate the math, but that they are culturally responsive in their messaging and they know how to engage in supportive interactions with people. That's a huge tenet of cultural humility. When people are presented with a problem like numeracy, we can feel very anxious. We can get sort of like, kind of feel like you're back in school a little bit. And so when you put people in that position, we want to kind of think about how that's not really conducive to a great healthcare environment to kind of make people anxious about numbers, when we could really think of a different way to be presenting this information so that someone has it accessible from the get-go and doesn't have to start doing the translation. Provider factors can also relate to their quantitative skills, their basic computational skills, estimation and statistical literacy. And this can be things like converting between units of measurement, right? Right now, I do a lot of cooking, and so I go a lot between cups and grams, depending on where my recipe comes from. It is not as easy as you think. And so when people are sitting there, it's like, do I even have the ability to quickly kind of move between these different kinds of measurements, as well as understanding things like the positive predictive power of a diagnostic test, right? So it's not just quantitative information for patients, but looking at this screening test and being able to understand and interpret the results. There's also a factor related to the provider's ability to use the information artifacts. Much like with a patient, their ability to navigate the document, interpret the graphs, translate between representations of the same information. This could be helping a patient interpret a graph of patient lab values over time, applying the numerical output of a decision support system to an individual case, right? So if you have clinical decision support tools and you're using, I know our HIV national curriculum has a lot of tools that you can kind of screen and assess people, and then you kind of get this output of a number, and then you're supposed to be able to take that number and then understand a little bit more about what's going on. This last factor, again, same thing as we saw in patients, information design, the ability of a system or document to support the provider's cognition. This could be things like designing a provider interface that provides the automated conversions between the units of measure. So instead of relying on the provider's quantitative skill factor that we saw a couple up, erasing the quantitative process from the get-go and doing the math for the provider so that that piece is always right. So when you think about these different factors, again, looking at quality improvement, I could be doing a project that helps build provider skills, both in oral communication of numeric information or quantitative information, but also potentially delivering quantitative information to communities with limited health literacy or individuals whose primary language is not English. You know, what adaptations do we need to make? What tailoring do we need to do? How do we make sure that the information that we're presenting is useful? You could also be looking at things at how you present information to providers. I can tell you that in our quality improvement projects, when we stopped looking at all patients for viral load suppression and kind of guided providers to look only at those patients that were non-suppressed, we saw all kinds of different things happening in the clinics and agencies and organizations because we just kind of presented information in a different way to them. And in that difference of information, they were able to see different things. So really thinking about the information design and what you want the provider to do with that, right? Those are all areas where you could do, I think, a really great and robust quality improvement project. So let's say you were to decide you want to do something in this space and you want to kind of build skills or competencies related to health numeracy. What I'd like to do is review a couple of areas that you might think about that are related to numeracy. So these three areas represent skills and competencies associated with health numeracy. They include accessing information, analyzing information, and applying information. So what we'll do is we'll take a look at each one of these. Under accessing information, we have things like representational fluency, document literacy, and graphical literacy. In analyzing information, we'll talk about basic computation, estimation, and statistical literacy. And in applying information, the concept of risk benefits, health regimens, and short-term versus long-term, this comparison concept. So when thinking about these skills for understanding information artifacts, when looking at accessing information, representational fluency is the ability to translate between and recognize the identity of different representations of the same quantity. So for example, one of the questions I always like is you can tell generally what generation someone is from by asking them how they were taught to eat food. Some people got a pyramid, some people got a plate. Now there's like a plate and a pyramid together, all these different ways. And what I remember most is they kept saying that you should eat a portion of meat that is equivalent to the size of a deck of cards. Another person told me it was like your fist. The size of sort of your fist is what you're looking at. Those are all examples of like representational fluency. Can I take the concept, right, that I'm being given and apply it in a different place and understand it? So if I say, go eat a piece of meat the size of a deck of cards, there's a lot of assumptions there that I've got to think about, which is, does the person I'm talking to know what the size of a deck of cards is? Does everybody have the same touch point for a deck of cards, right? One person's fist is very different size than another person's fist. So representational fluency is kind of in that space, that when you give me a piece of information that is kind of comparing or representing something else, that I understand that representation. Document literacy is about this idea that, you know, when you're looking at a document, and CMS has a great, Center for Medicare and Medicaid Services has a great resource about improving health literacy in documents. So if you are into this kind of thing, it's like 400 pages long. It's huge. There's a lot of information, but it helps you understand things like document literacy, which is often when we put things out, we put them on paper and we are focused on getting the information out, or maybe it's in like a particularly academic format, right? We kind of speak to our disciplines. That is not always how most people go through documents. Quantitative information is often provided sometimes to people in the form of complex print or electronic documents that combine text with lists, forms, or tables. So when we think about document literacy and we go back to that list of like all my labs and they were all presented in that information, it was just confusing. I don't know where to go. I don't know what the important information is. There were no supports on that table. It was just a chart. The other thing I find too, and this I think happens with anybody, if you go to a meeting and you're kind of looking at data and somebody drops in front of you 700 pages of Excel that you've not looked at, that can be overwhelming, right? It's like, whoa, I need to sort of like stop for a minute and I need to like take a look at this, because the way you've presented this information, while in tables and very robust, and I'm so glad to have all of this raw data, that's really hard to look through. The other thing to know about document literacy is it's not just about like, you know, all these numbers on paper. There are like ways people's eyes move in documents, and that is also culturally relative. So different cultures read in different directions based on the language system that they use. And so you have to kind of understand how things like reading gravity work. Reading gravity is a concept around document literacy, which is, does the document flow in the way the information goes, in the way gravity pulls my eye? So for example, most folks who use English as their primary language and are reading a document will read from left to right, top to bottom. So if you are doing document literacy and you're thinking about something like reading gravity, you want to make sure your information is presented in that way. If I try to put like a really fancy thing at the bottom of my document, my eye is going to immediately be drawn there. That's the gravitational force of the document. So if you put that there, that better have been the most important information, because I probably skipped everything before it, right? So thinking about document literacy is not just, can I look at the document and kind of understand all the pieces, but again, thinking about that system perspective, can this information be presented in a different way? Am I paying attention to sort of cultural norms about how documents are constructed and read, not in a medical environment, but like by everyday people walking around? Another skill in this area is graphical literacy, which is the ability to interpret graphs, right? In our training of consumers on quality, which was a training program we developed for persons with HIV to increase their involvement in clinical quality management, as well as the Elevate program that's available now through NMAC to build the capacity of persons with HIV to deliver, plan, and improve services. We focused a lot on graphical literacy, presenting lots of different tables, charts, pie chart, bar chart, Pareto chart, right? Because all of this information comes at us. We see it in our newspapers, we see it in education materials, We definitely see it in healthcare. And so graphical literacy is if I put a graph like a pie chart on my, information sheet trying to show people their percentage risk of, having prediabetes, if somebody doesn't understand a pie chart or a bar graph from the get-go, that is not going to be an effective way to communicate, right? We try to sometimes get past that where we'll make our bar charts like little people and we'll like fill them up to the person. Those are all great ways to make that more accessible, right? So that I don't necessarily have to understand a bar chart to understand that when you give me a person and you fill it halfway up, that's 50%. That's some graphical literacy that you can utilize, right? So it's not that, again, that you've got to teach every patient to all of a sudden, understand every data visualization out there. There should be like a mix here, right? Like, can we provide some education to make sure we've got level setting in what we expect people to understand? But can the system also create information and present quantitative information in a way that doesn't overburden what the patient has to learn, right? So really thinking about how both sides of the equation could be addressed in a quality improvement problem, both building graphical literacy in a patient community that might be limited, while also designing better materials. When thinking about analyzing information, things like basic computation, estimation, and statistical literacy, basic computation, this is things like number recognition, that I can even look at that and know what that is. Comparisons, but I can look at two choices and be able to understand what I'm being given the option of, and that I can make an informed decision about that choice. Arithmetic, right? Just basic addition, subtraction, and the use of simple formulas where people are sometimes, if this, then this, and I might have to do a couple of calculations in order to get to the answer that I need. But I want to draw you back to that first part, number recognition. Number recognition, there was a great article in the New York Times back in, I think it was like 2011, and they highlighted a program that teaches math called Jump Math. And it was all about how we teach math in a very disempowering way, where children are presented with a math problem and they either solve it correctly or they solve it incorrectly. And if they solve it incorrectly, we expect them to go back and correct it again. That me versus the problem creates this really strange environment where people who continually get it incorrect, even though we know math is a skill and it takes time to build, that people end up disengaging from math, right? And so we end up in a place where, let's say you're sitting at a dinner party and someone says, I can't do math. Everyone goes, oh, me either, right? But if you said like in that same party, I can't read, people would like stop. They'd put their glasses down. They'd be like, oh my gosh, how can we help you, right? Like we would want to help this person read because we couldn't imagine how you could walk through the world not having literacy, right? We have so many programs aimed at building literacy globally, right? Because we know how important that is. And yet when someone says, I can't do math, we generally have a chorus of people joining in saying me either. So when you think about number recognition, there's even that idea that like you put a math problem in front of me that I perceive the agency or I am empowered, that I even can know what to do with this information. I spent a lot of my time as a sort of when I was newly diagnosed thinking about this a lot, which is why in our training program, we really focused a lot on helping people sort of change their relationship with numbers, sort of recognizing that a lot of folks feel very unskilled in that space. So instead of starting with an expectation, we reoriented how we taught math and we put people in rooms together. We gave groups of people problems and had them solve them in a communal way. This was far more successful than having a people one-on-one. So this guy who taught this math program, Jump Math that I mentioned, he also called it Math for Social Justice because it helped communities learn to solve problems together from the time they're children. So when you're thinking about a QI project, think about how communities of people could be engaged to think about reorienting their relationship with data. I know that sounds nerdy and wonky and weird. Yes, Jen, in the chat room, Jump Math, and it's JUMP, and he puts an exclamation point after it. And it comes out of Canada. What I'll do is make sure we give the citation here to CQII so folks can follow up if you'd like to read the article about it as well. The other individual level competencies related to analyzing information also include this estimation, right? Using estimates instead of calculations to make decisions. So for example, when my mother goes to a restaurant for dinner, they don't have the little boxes that tell you, how much pasta is here and, what kind of pasta it is and, how many grams is this portion. And so she's got to kind of look at her meal and estimate what she thinks is in that, because she has to, do her insulin in relationship to how much she eats. So this is that ability to do that, right? Can you look at something, and if you can't or don't have the ability to do the math, can you estimate, right? There's also this idea of statistical literacy, and this is really about understanding of concepts related to change, uncertainty, sampling, margins of error, and randomization to evaluate scientific information. This is stuff like, if you're a person with HIV, you're at, 15 times greater odds of having X happen to you. That can sound pretty scary, and I can just all of a sudden reorient and change all my behavior. But then I find out later that my risk of that happening was 0.0003%. So my 15 odds greater, right, brings me to like 0.1%. So if I didn't understand that, think about people sort of walking around, right, kind of looking at all this health risk, watching all the pharmaceutical commercials telling you like, oh, 5 out of people, blah, 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 blah. So that's people's ability to understand all that information, so that when someone says your odds are increased by 3% or 3 times the odds, that you have a foundational knowledge to be able to do that. And this becomes really important when you put it into that comparison skill set as well, because often as patients were given choices, right? You can have this, you can do this. There's X percentage chance this will happen with this pathway, and X percentage chance this will happen with this pathway. And then often we ask our doctors, well, what should we do? And they'll be like, well, that's your decision. If that's my decision, then I really, really, really need to understand the outcomes of those 2 pathways. And so when presenting statistical information and you're giving people treatment choices, you got to think about the statistical literacy associated with that choice. And am I presenting information that people are going to be able to use? Or do we need to really spend some time sitting down, and going through these numbers to make sure somebody understands the choice that they're about to make? Lastly, there are these skills associated with applying the information, right? And so this has to do with being able to evaluate risk and benefits of health options. This gets a little bit at the statistical literacy that we were talking about. It's also about being able to follow complex health regimens. Right now, a lot of us have the privilege of only having to take 1 pill a day for our HIV. It was something, I was diagnosed in 2005. I was immediately put on 1 pill a day. There are a lot of folks in our community who started out on many pills, who are still today on many pill regimens, who have comorbidities besides their HIV, that have multiple pills and regimens and things they've got to be doing, and take this with X number of calories, but only do it at night. That is really complicated. And it's complicated not just because there's a lot of instructions, but it gets more complicated when those instructions have quantitative information associated with them, or some kind of calculation or computation that needs to be done as part of that choice. Lastly, there's this ability to apply short-term and long-term benefits. And again, no one of these things sort of rests without the other skill set, because do I understand the statistical, aspect of the information you're presenting? Do I have the comparison ability to be able to kind of see these? Can I estimate what my short-term and long-term sort of benefits will be based on all of the factors in my life? So you've got to really think about, not just these sort of like abilities to access or analyze the information, but really thinking about the synthesis, which is taking all of those sort of, different skills and different types of literacy and kind of putting them together and then using them. Because just having a knowledge of a skill isn't a skill, right? I have knowledge of it. A skill you have to practice, you have to use, and you have to apply. So think about then, if you feel like you've got a pretty, literate population, but maybe it's just the application is an area where you think there could be improvement. You could be thinking about, there's some great tools and resources out there that teach patients, especially coming from the diabetes realm. They do a lot of work in this space to help people understand these things. Training programs, curricula that you can adopt, or even just little brief interventions that can be done with people using a lot of the recommendations are visual aids, right? Helping people with visual aids understanding risk and benefit. So the last piece that I wanted to do here before we close out today is offer folks some recommendations and tips from some various places in the literature around how you could be better presenting numeric health information, or if you're presenting it really well, how you might polish it up and make it even better. So a couple of things to think about. Some best practices in presenting numeric health information. First and foremost, less is often more. Right? So like if you got a lot of information to give me, chunk it, just like we would in adult learning, right? Give me the pieces of it that are going to help me move through it and understand it. Reduce required inference and calculations. If I don't have to do the math, don't make me do the math, okay? Test formats carefully to reduce numeracy effects, right? So when you're looking at how you're presenting information, don't just do it once, test it out. Are people able to do this? Can they actually follow the instructions that you've given them? The other thing to think about, I mentioned earlier, are the visual aids. There's a lot of great programs that have you sort of like ask a question and then hold a visual aid, and then ask a question, hold a visual aid, and you kind of move between these discussions with these visual supports. There's also a lot of really great health tools I've seen. We use these a lot in HIV prevention, where like you flip, you have a little workbook, and like on the front side faces the patient or the client, and the back side faces the service provider. And you can kind of move through information that way using those kinds of visual aids to help present what could be otherwise pretty complicated information. You know, we were trying to explain untreated and unmanaged HIV, right? That gets so much easier when you have a visual aid, and you can kind of, while describing the science and the numbers, also have a picture. Other things to think about when approaching health numeracy is, and as a patient, I know this is going to sound weird, but just assume everybody lacks knowledge of quantitative concepts. Like that is how like grossly limited health numeracy is in this country. It is better to start from a place assuming no one has these skills than to try to, you know, kind of cream out the top and kind of find the place. Like most folks need help in this area. Try to focus on one idea at a time, right? So don't come in with too many things all at once. You know, maybe if I have HIV and diabetes, you know, maybe one conversation focuses on the management of HIV, and then at another time we have a conversation that focuses on the management of my diabetes. When you put those two things together, those numbers can start stacking on each other, and it can just get really confusing. Another one is only use numbers when they're really needed. So again, patient portal, chart, all of those tests. The one that was most important, viral load suppression, not even on that chart, right? So like, if you don't need to put those numbers in front of me, if there is nothing I need to be concerned about, maybe don't put those numbers in front of me. If I ask for them, sure, great. I should always have access to every piece of data that generates from my body. But maybe I don't need it all at once that way, right? And part of why we come to healthcare is to help narrow that stream of information. I think many patients expect our providers to really sift through this information and really only present the things that are most relevant. You also want to find out what measurement system your patient uses. I have lived outside the United States many times. Everybody, it's not the same. We're the weird ones right here in the US. Everybody else tends to use a very different measurement system. So when you're telling people to like, you know, drink 8 cups of water, that's a fascinating question. Do you mean like a cup like this? Do you mean a measurement cup? Because that's what we use here for most part in the United States. Although get out of the United States, a lot of people are like, a cup of what? What are you doing? So you got to think about how people measure things so that if you're giving advice to people, the measurement system that you're advising them in is the same. You also want to make sure that you offer support for ideas. And so this is about, you know, if people have an idea that they want to do something different and they're like, hey, we could do this, we could do that, or hey, I've got an idea, support that, right? Helping people really contribute and be a part of it, especially when it's their own health, right? When you're offering support, this can be things like drawing a picture, right? So, hey, I can see this is not kind of like getting through. Let me try to draw something. So like if somebody's not understanding temperature, draw a thermometer, right? Kind of show like where you're getting too high. You can do things like use analogies or reference points to explain quantity, right? So there I just talked about a little earlier having, you know, a meat the size of a deck of cards, right? That is kind of using an analogy or a reference point to help understand quantity. Show physical representations of quantity. That's that give me a picture, right? I often see like people are like, oh, it's this big, and they put it next to a quarter or a nickel. There's always some reference point that helps you sort of understand the scope or the size of what they're talking about. Encourage patients to create their own images, right? Help me understand, right? Turn over the power, right? Draw for me what you think is going on. Use vivid language. That's just meaning like be descriptive, right? And teach with story. As a patient and also a person from Appalachia, like we live in oral narrative, right? Community for us is story. And many years ago, people asked me, how do you improve care? And my answer has always been, you improve my story. Many communities, right, have been, denied the right to write down all of their history. And so culture has grown to really value story. So you want to engage me, sort of use the sort of construct that we use to engage, right? Teach with stories. People love stories, right? So like help thinking about different ways that you could be supporting individuals if they're not understanding or that just start that way, right? I've had really great doctors in my past who like have these little whiteboards they carry around. And it's like all of a sudden they just start drawing and they go at things and they're really, it's very helpful to be able to see and understand. So thinking about how you could be supporting folks. So the key points here, a couple of things. One, patients and providers need more skills and knowledge to understand and communicate quantitative health information. And there are different skills that you need to have. And these are related to things like accessing, processing, and applying numerical health information. Providers should closely evaluate their use of numbers when explaining health information to patients. If you can take it out, take it out. Remember that a picture is worth 1,000 decimal points. If you can put it in a picture, definitely do. It is far faster to understand. It will not only be more accessible and more understandable, it will save time, right? Everybody, I'm hearing it all over the place. We don't have enough time. We don't have enough time. This is healthcare. Visuals are a way that you can shave off little amounts of time, but it's a lot of time over time, okay? Last part, make the numbers that you do have relevant and meaningful. Often if you can use that storytelling technique to situate that information into something that is accessible or I understand or it's going on in my life, that is going to help make those numbers more relevant and more meaningful to me as a patient. So here's the contact information for CQII, but with that, I would open it up. If folks have any questions or any comments, we will definitely make sure that I send out that information about jump-based math to folks for sure. Nobody leave yet because Shimei has polling that we have to do before we go. Oh, she's got it up.
Yep, it's up.
Awesome. So if folks have any questions, I will still be here. If you have any comments, feel free to use the chat room, but please make sure that you complete the evaluation and we'll stick around for a while. Thank you all for coming today.
Yeah, I was looking through the chat to see if there was any questions, but okay. There's Albert, there's tons of training CQII offers. The link I put in earlier about where this training is going to be posted, there's loads of previous trainings already there. Feel free to binge watch as much as you want.
Yeah. And I would say too, Albert, if you have any specific questions about any of them, there are different programs kind of situated in different places now. So like, for example, our training of consumers on quality is a program that's now part of NMAC's Elevate program. We also have our training of trainers, our training of coaching basics, training of quality leaders, but we have both provider and consumer focused ones. So depending on what you're looking for, we can sort of guide you in each direction.
Yeah. Adam, question, are you willing to share your contact information in case somebody has specific questions for you?
Oh my gosh, absolutely. Sorry about that. In case you want to bypass Kevin.
Yeah.
Don't tell him I said that.
Yeah.
Yeah, no, anyone's feel free to reach out. Like I said, we've got a couple of journal articles that we can send around to folks, but the assessment tools as well, if folks are interested in the ice cream label assessment, we'll send that out to folks. I believe it was, I'm trying to remember the company that put it. It was a private company. It was like a pharmaceutical company, but It's a great tool, and we've definitely had folks try to use it before. Oh, and I see Patrick said he's on the CMS website now. That is the coolest tool. Get ready to get lost for hours. I learned about so many different ways you could design a document and think about designing a document that I had never even crossed my mind that people would read that way. All right, well, are you good, Shay? Oh, what's the CMS website address? Great question. Oh, okay. I see Patrick said some of the download links are dead. I definitely have that document. So what we'll do is we'll find either the active link at CMS, or I'll just download the document or download it out of my files, and we'll put it up on glass cubes for everyone. And Jerry, yes, the ice cream assessment.
He found it on Google. Google's the place.